Dr. Silver's Pathology. Pathogenesis of ovarian epithelial tumor. Hi guys. This is Dr. Silver. Today I'm going to be talking about the pathogenesis of ovarian epithelial tumor. There has been a change in the traditional model of ovarian epithelial cancer pathogenesis. The traditional view of peritoneal dissemination was that carcinoma begins in the ovary, undergoes progressive dedifferentiation from a well to a poorly differentiated tumor, and then spreads through the peritoneal cavity before metastasizing to distant sites. Recent studies, however, have provided evidence that the origin of ovarian cancer, traditionally regarded as the OSE, ovarian surface epithelium, is more likely the fallopian tube and other non-ovarian tissues such as endometriosis. Carcinomas of the ovary, salpinx, and primary peritoneal carcinomas are grouped together. The new model divides surface epithelial tumors into two broad categories, type 1 and type 2, based on their clinicopathologic features and characteristic molecular genetic changes. Let's take a look at type 1 tumors first. Type 1 tumors are low-grade, relatively indolent neoplasms that arise from well-characterized precursor lesions, atypical proliferative borderline tumors and endometriosis, and usually present as large stage 1 neoplasms. Low-grade serous, invasive micropapillary serous carcinoma, MPSC, low-grade endometrioid, mucinous, ceremucinous, and clear cell carcinoma, CCC. Type 1 tumors often harbor somatic mutations of genes encoding protein kinases including KRAS, BRAF, PIK3CA, and ERBB2, as well as other signaling molecules including P10 and CTNNB1 beta-catenin. This is a schematic of the proposed origin of type 1 tumors. Retrograde menstruation leads to the development of endometriosis and atypical proliferative tumors, which can give rise to endometrioid and clear cell carcinoma. On the left is a schematic of proposed mechanism for the origin of ovarian surface epithelial inclusions from fimbrial epithelium. Epithelial cells from fimbria implant on site of rupture on the ovary, where ovulation occurred. These epithelial cells can conceivably invaginate to form a cortical inclusion cyst. On the right is a schematic of the development of low-grade micropapillary serous carcinoma. Pathogenesis of low-grade serous carcinoma, which is a type 1 tumor. Next, let's move on to type 2 tumors. Type 2 tumors, of which the vast majority are HGSCs, are aggressive, high-grade neoplasms from the outset. HGSCs arise from intraepithelial carcinomas, the majority of which have been detected in the tubal fimbriae. TP53 mutations are found in virtually all HGSCs. Of further interest has been the detection of TP53 mutations in serous tubal intraepithelial carcinoma, STIC, and in a recently described putative precursor lesion of tubal intraepithelial carcinoma, designated as P53 signature. On the left is a schematic representation of direct dissemination or shedding of STIC cells onto the ovarian surface, where the carcinoma cells ultimately establish a tumor mass that is presumably arising from the ovary. Of note, there may be stages of tumor progression that precede the formation of a STIC. On the right, you can see the H&E and P53 immunohistochemical staining of a STIC. STIC and P53 signature are precursor lesions of pelvic serous cancer which are macroscopically inconspicuous. Immunohistochemistry for P53 and Ki67 may aid in the diagnosis. Microscopically, STIC shows atypism while P53 signature is not detectable without an immunohistochemical stain. This is a schematic diagram of the pathogenesis of ovarian epithelial tumors. Type 1 tumors progress from benign tumors through borderline tumors that may give rise to a low-grade carcinoma. These include low-grade serous, endometrioid, and mucinous carcinomas. Type 2 tumors arise from inclusions, cysts, or fallopian tube epithelium via intraepithelial precursors that are often not identified. They demonstrate high-grade features and are most commonly of serous histology. This table summarizes this lecture. Pause for a moment and take a look. References are as follows. Thank you for listening. If you liked the video, subscribe Dr. Silver's Pathology. See you next time.